they are treated with the intra-arterial chemo. So I'm not very surprised with growing number of participants.
Good morning from Brazil.
Okay, if you agree, we're probably going to start to not delay too much this webinar. So far, we have 240 people connected. I'm pretty sure that we're going to have much more in the few seconds coming. I would like to thank everybody from all over the world for joining us. On behalf of Balt and Jose Angel, who organized this webinar, I would like to thank Dr. Bartolini, Professor Sayou, Professor Jabour, Dr. Flavio Requejo, and Dr. Piotr Rago, who are well-known experts on retinoblastoma and have accepted to share with us this afternoon their knowledge and their tips and tricks on the treatment of retinoblastoma. We're going to have 4 speakers today. Each talk will last approximately 30 minutes. And then after each talk, we are going to have a question and answer session. Then therefore, I kindly ask you to, if you have any question, to use the Q&A module and to write your question in this module that we will review with the speakers at the end of their talk. And I would like to now officially start this webinar and ask Professor Sayou if he's okay to take the lead and share his slide deck.
Okay, thank you. I'm Bartolini from Lausanne. I'm gonna start the webinar. I hope everybody can see the slide deck. Thanks to Balt for this invitation to share our experience for intraarterial chemotherapy. Just a small introduction for retinoblastoma. Retinoblastoma is a cancer of early childhood. Its incidence is slightly dependent on age. In Europe, from 0 to 1 years old, we have more or less 20 cases per million. And then it decreased to 7.5 cases per million from 1 to 4, and 0.5 cases per million from 5 to 9. It can be hereditary or an acquired disease. It can be unilateral, bilateral, and in few cases, just in a hereditary disease, can be trilateral, and you have to perform an MRI scan to look for the tumors in the pineal gland, or less commonly in supra or paracellular region. There are a lot of classification for retinoblastoma. The one we use in Lausanne is the International Intraocular Retinoblastoma Classification. There are 5 groups from A to E. Most of the cases that we do in Lausanne with intraarterial chemotherapy are done for the group D. Just some historical news about intraarterial chemotherapy. Yaman et al. In 2004, they described the technique with the balloon. The balloon was placed in the carotid artery, distally to the origin of the ophthalmic artery. There was a temporary occlusion of the carotid siphon, and the chemotherapy was delivered in the catheter. Then in 2008, Gobon in New York described the super selective intraarterial chemotherapy with the catheter that stay at the origin of the ophthalmic artery. So all the chemotherapy goes to the orbit and to the tumor. That's the technique that we use in Lausanne, and I think that more or less now in all the centers they use this technique. This graph I show our experience. We started in 2010, and in 2012 we just did 23 procedures, and then we doubled the procedure to 52. And in the last 4 years, more or less, we did between 90 and 100 cases per year. Some technical aspects. All the procedures are done on general anesthesia. We normally use, at least in babies up to 3 or 4 years old, a 3 French sheet of 50 centimeters. We always puncture the common femoral artery under ultrasound. And after the puncture, we give 40 units per kilogram of heparin, and we control with ACT at the beginning and at the end of the procedure. The technique, then we navigate our microcatheter. We normally use 1.2 Baltacci FP. It is a short microcatheter over a micro guide wire. We use the hybrid 07 to the origin of the ophthalmic artery. Then we inject, we use 2 drugs, melphalan and the combination of melphalan to protecan in cases of relapse or treatment failure. The melphalan is injected in half an hour, or the melphalan, when we use the 2 drugs, we inject in 20 minutes the melphalan and in 10 minutes the topotecan. We just do pulsatile and injection. And the infusion rate is more or less 1 milliliter per minute. By the end of the procedure, we do a manual compression for hemostasis. And then we put the compression bandage for at least 4 hours, and we discharge the baby the same day if the procedure was done in the morning, or the next day if the procedure was done in the afternoon. And normally we do at least 3 sections of melphalan every 3 weeks. Some other consideration for babies: we try to use a small quantity of contrast media. We do not exceed 6 milliliters per kilogram. We use a special pediatric program to reduce X-ray dose, and also we remove the anti-diffusion grid from the fat panel. I'm going to show the normal procedure from the internal carotid artery. We call it the pull-down technique. As you can see in this video, the microcatheter is in the siphon distal to the origin of the carotid artery, of the ophthalmic artery. We pull the microcatheter, we jump in the ophthalmic artery, and then we put a little bit of pressure just to stabilize it. That's quite simple, quite quick, and it works very well. Unfortunately, sometimes we can have some problem. That's the run from the ophthalmic artery and the choroidal blush, and then we can do the chemotherapy. Concerning some problems, sometimes the microcatheter is not stable, so we can shape it with steam. We do not do very often. Most of the time, we try just to get to the origin with the micro guide wire to add more stability. Another problem that we can have, the microcatheter is stable, but we have a lot of reflux into the internal carotid artery. In these cases, if we see the choroidal blush, we still do the chemotherapy from the origin, and then we check, which we wait for 3 weeks, and in the second session, sometimes we change strategy. And the second problem that we can have, that the microcatheter is stable, but we have a lot of flow that's coming from the external carotid artery, and we do not see the choroidal blush. So in this case, the first things to do is to check for vasospasm of the internal carotid artery. If we do not have any vasospasm, we have to try different approach. Concerning different approach, we can get inside the ophthalmic artery, even in small babies, from the internal carotid artery. You can see the run from the internal carotid artery, the ophthalmic artery. We can get inside. We prefer to use a more floppy catheter. We were used to use the Magic 1.2, or always with the hybrid 07 to get inside. You see the microcatheter. You see the run from the ophthalmic artery, and you see the choroidal blush. Then you can do the chemotherapy. Another technique is the retrograde approach. You see the run from the vertebral and basilar artery. You can go through the posterior communicant artery. With the microguide wire, you can get inside the ophthalmic artery. microcatheter, ophthalmic artery, choroidal blush. You can also go from the external. As you probably know, there are a lot of anastomosis from the internal to the external in the, with the ophthalmic artery. The one we prefer is the second portion of the ophthalmic artery with the medial meningeal artery, because it's the largest one. An example, the one from the internal carotid artery. We do not see the ophthalmic artery. So we go from the external, internal maxillary artery, medial meningeal artery, ophthalmic artery. You can go all the way up with the microcatheter. And you see the microcatheter, the ophthalmic artery, and the choroidal blush. So then you can safely deliver the chemotherapy. It's the same case, it's anteroposterior microcatheter and choroidal blush. We did 2 cases of medial meningeal artery occlusion when you have a large medial meningeal artery coming from the ophthalmic artery. You can see the microcatheter at the origin of the ophthalmic artery, and you have a large medial meningeal artery. The first session, we stay at the origin, but unfortunately, the tumor was stable. So we decide to sacrifice the medial meningeal artery. As you can see, we get all the way to the medial meningeal artery. We put some coil, and then we deliver the chemotherapy. That's the first control at 3 weeks, and this is the last control at 6 weeks after 3 procedures. Concerning local complication, you can have a lot of, in many cases, you can have a retinal detachment that is secondary to the shrinkage of the tumor. You can have ischemic complication for retinopathy or chorioretinopathy. You can have secondary cataract, and you can have all the complication in the orbit. I'm going to show you some cases. This is a complication of ptosis of the left eye. Another complication of the erythema in the forehead on the right side. This part of the forehead. Concerning local complication, in our center, the rate of secondary chorioretinopathy raised in the last 3 years, from 2017 to 2019. We don't know why. There are some hypotheses. Can be some ischemic event, like occlusion of the ciliary arteries. It can be an hypoperfusion. It can also be the toxicity of the melphalan and melphalan protectant. In this moment, we're going to try to understand why we have this rise in complication. And in 2020, we changed a little bit our practice. So we reduced the number of retrograde approach when you have the catheter inside the ophthalmic artery, so the flow probably to the orbit, to the eye is lower. Or you have we reduce the distal navigation to the ophthalmic artery. We became a little bit more permissive with the reflux into the internal carotid artery. And we take more time to shape the catheter or to use the microguide wire to stabilize the microcatheter at the origin of the ophthalmic artery to avoid to enter inside the artery. In the last slide, this last slide, I'm gonna present some complication in general anesthesia. You can have some hypoxia, reduced lung compliance, systemic hypotension, bradycardia. You can have it when you get in the carotid bifurcation, and in most of the cases, you can have it when you get at the origin of the ophthalmic artery. Normally, they last less than 5 minutes. Pediatric anesthesiologists, they can manage very well, but the doctors must be present during the procedure. Thank you.
Okay. I will continue with general consideration of endovascular treatment in children, and we'll show you some the worst complication we had. I think, hi everybody, I'm William Selliou from Lausanne. I think most of people are always interested in our complication. Okay. We don't have any conflict of interest, especially we were not paid. Maybe we should have too, but we didn't get any money from BALT, and for this webinar especially. And I just want to share our experience, just to save contrast, to save femoral access, to save time in these young children, sometimes babies, and some tips and tricks just to avoid any complication you can easily have in children that you will never see in adults. Just for general consideration regarding the amount of contrast, we limit always our procedure to 6 milliliters per kilo. Most of the time, it's enough for a straightforward procedure of intra-arterial chemotherapy. This could be different if you have to treat a shunt in a vein of Galen, for instance, or PL fistula in baby, but procedure for intra-arterial chemotherapy are very short most of the time. And pay attention to your perfusion as well. Perfusion of your catheter is always drop by drop. Otherwise, your baby can be full of saline, and this could be an issue for the anesthetist with the risk of pulmonary edema. Don't forget that you have small arteries, and we always limit the size of the introducer to 4F. Now in our routine protocol, we use 3F long sheet from BALT, which is perfect for this kind of procedure. We always avoid bilateral femoral access for all intervention in young children or babies. And arteries are weak. And if you don't want to damage the artery, especially the femoral access, it's better to try to have a short procedure, less than 45 minutes in babies or in children less than 6 months old, in our experience. And I had some question about tortuosity in babies. Was it normal or not? It's always tortuous. This is just normal picture of baby. You can see 6-year-old young lady, 1-year-old baby. You have a loop here. You have tortuosity everywhere. This is just normal. No need to look for further disease of the soft tissue, for instance. No need to do investigation for that. This is just normal. So don't try to push your introducer over this loop, otherwise you can have a dissection of the vessel. Don't forget it's weak vessel. And in very young baby, what can happen sometimes? You want to go to cross to do your puncture. You push your microcatheter, and you want to go to the cervical arteries, and you can go through patent ductus arteriosus, which is rare in case of retinoblastoma, but in newborn, this can happen. And before you understand where a catheter is, it can take a while. You can do a run. You don't understand the anatomy. It's very weird. So if you don't understand anything, maybe you just cross this ductus arteriosus, and you are in the pulmonary artery actually, and not in the aorta. So remove everything, and you will finally find the right way to go into the cervical arteries. how we do, we always diluted the contrast with 1/3 of saline just to save contrast. Even in straightforward procedure of intraarterial chemotherapy. Just an example, Bruno already showed you, but here we do a run. We put the long 3F sheet into the common carotid artery. We do a run with 4 cc of contrast and 2 cc of saline, so it's very few. And then we do a roadmap. We can navigate without any contrast injection. We do the navigation as before. It's the push and pull and push. And when we are in the right position, we just do a run with pure contrast, with less, most of the time less than 1 cc of contrast. We deliver the drug, and at the end of the procedure, we repeat a run just to check if everything is normal. Most of the time, at the end of the procedure, you will see that the choroidal blush is a bit blurred, not as nice as the beginning of the procedure. We observe this kind of changes over the treatment. Maybe it's some kind of edema due to the drug. We don't know exactly. But this is just normal. The blush choroidal. The choroidal blush is always seen, but sometimes not as well as the beginning of the treatment. So in this kind of treatment, you can just use 10 cc or 12 cc of contrast, which is very few, and you don't have any risk of contrast overdose in this kind of patient. And pay attention to the femoral access. Here it was not a angiogram, femoral articofemoral angiogram. After chemotherapy, it was a baby who had a vein of Galen malformation and treated several sessions after birth. You can see that here it's occluded. And even if you feel good arterial pulsation at the level of the groin, that doesn't mean that the femoral access is patent. We always check the femoral access with ultrasound, especially if the baby already had a femoral puncture in the past. And keep in mind that during the procedure, if you look at the other side, the perfusion of the lower limb can be decreased. So don't stay too long on the baby. Otherwise, there is a risk of having a lower limb necrosis. That's why we limit the length of the procedure in babies less than 6 months to 45 minutes. We can go up to 60 minutes if in rare case, we try to do as short as possible and to do 2 interventions and not everything in a single long intervention. So we do all our puncture on the ultrasound guidance, and we never do any conventional angiography for diagnosis. We never do bilateral femoral access, for instance. We use now 3F long sheets, which are very nice to do this intervention. I think we use the one from BALT, but I don't know if there is another company who do it. I'm not sure. And to save this femoral access, the shorter procedure are always the best in my experience. And just a word regarding the risk of endovascular complication. In our experience as well, the age is likely much more important than the weight of the baby regarding the risk of complication, especially hemorrhagic complication. Hemorrhagic complication which reflects the weakness of the vascular network in babies, looks mainly correlated with the age of patient, no matter the weight. With the threshold at 3 months, we did this retrospective review and it was published in Journal of Neurosurgery in 2019. It was 80 sessions of embolization in young baby in 53 patients, less than 5 kilos, and all the triangles correspond with hemorrhagic complication. As you can see, doesn't depend on the weight, but it will depend on the age of the baby. The maturation of the vascular system seems much more important than the weight of the baby regarding this severe treatment complication. So this should be very rare in intraarterial chemotherapy, because most of the time the baby are older than 6 months. And this is our severe complication we had. We did about 350 intraarterial procedures since 2016. We had only one clinical cerebral ischemic complication. Maybe we had asymptomatic complication, we don't know, but we don't do an MR after procedure. So we only had one which was symptomatic. We use heparin at that dose. It's 40 units per kilo once the introducer is in place. And we never had any severe hemorrhagic complication. We had limited growing hematoma. It's very rare. Even if the size of the introducer seems very big compared to the size of the artery, actually it's very easy to do a manual compression on the growing of a baby. And most of the time we will have a kind of severe vasospasm of the artery after removing the introducer, which helps to do the hemostasis. And we had one uneventful overdose of heparin, but the anesthetist inject a huge amount of heparin. And regarding this heparin overdose, at the end of the procedure, I noticed that after 5 minutes of manual compression, there was still unusual pulsatile bleeding from the artery. I did 5 minutes of additional compression, and still the same. Therefore, I asked the anesthetist if he was 100% sure that he injected the right dose of heparin. Of course, he was sure. And I asked him to check all the vials he injected. And therefore, he realized that heparin was available in 2 different type of vials in our institution. One which is tenfold more concentrated than the other, which used by mistake. So he injected a huge amount of heparin, and if you do that before during a procedure where you treat several additions, you have a high risk of having a severe brain hemorrhage. Hopefully, in this case, the patient was lucky, and we did an ACT at the end of the procedure. This caused a machine to bug. It was unable to go up to 10 minutes, so we didn't know the right ACT we had. It was more than 10 minutes, which is just not normal, of course, and we reversed the heparin with protamine, and the patient was fine. So always be very careful with that, and ask twice your anesthetist to double check the amount of heparin used. And regarding our 2 worst cerebrovascular complications we had an occlusion of an artery, I will show you, and a severe brain ischemia. The first complication happened in a 11-month-old young lady. She had a bilateral retinoblastoma. We wanted to treat this one. We was targeted on this one. You can see the run of the common carotid arteries. The ophthalmic arteries was almost not seen. Anyway, we went in, and we had some stagnation in the ophthalmic artery. Probably we had reverse backflow into the ophthalmic artery, and all the contrast went back into the carotid artery. So this is, of course, not nice to inject drug. Everything will go into the brain and nothing into the eye. So we would look for an external access, and we didn't find any supply to the orbit. And we went in through the PICUM. You can see here it's the posterior circulation, the right PICUM. And my colleague, I think, did a mistake. He pushed his 3F long sheet into the left tiny vert, and the dominant vert was the right side. So we probably had some blood stagnation and clot formation into the vert. This is the procedure, went from the posterior circulation. And you can see here the clot into the pica. We remove the clot by using a headway 27. Don't forget, it's very tiny vessel, and we are in very weak arteries. Maybe we could have let this clot in place, but we decided just to try to do an aspiration. We used the 27. It was into, I think, a Sophia 5F. I pushed all of the Sophia 5F all the way up to the origin of the pica. And after 2 attempts of aspiration in the headway 27 and Sophia, we managed to get this result. We opened the vessel. Here it's in basal stratum. You can see this is the MR performed at day 1. The artery is perfect, and only a very little hit and with the patient which remained asymptomatic. And second complication, much more severe, we'll see, always bilateral retinoblastoma. We wanted to treat this right side. We did the treatment, which went fine regarding catheterization, but and the patient was discharged the same day. But during the intervention, the anesthetic had some issue with the blood pressure. It didn't tell us that probably he was unable to measure the blood pressure for almost 10 minutes. He tried to do it itself, but we can have some reaction sometime on bradycardia, as Bruno told you, and probably this happened. He didn't tell us anything, and we did the procedure as usual, and but probably the patient has very slow flow during this intervention, and you can see this brain ischemic damages. It's tough to know if it's hemodynamic infarction or embolic shower emboly. You can see we have infarction from the other side. We went only in the right carotid artery, and we have infarction as well in the posterior left posterior cerebral artery. So we don't know exactly. Here it's probably watershed, but sometimes it's difficult. We went back on the images at the end of the procedure. We didn't identify any occlusion, any vessel occluded in the brain. It was difficult to find any occlusion on the MRA as well. So we don't know, probably it's shower emboly, maybe it's hemodynamic infection, we don't know. And just to show you some hemodynamic infarction in baby, sometimes they can be totally different than in adults. This patient, I will show you 3 patients who never had vascular catheterism. It was MR performed at birth in a patient with high flow vein of Galen malformation. You can see here brain infarction. It's only hemodynamic infarction here. Another one, infarction here. Another infarction which can be a bit different than that, what we can see in adults. And I thank you I think it's the end of the presentation. So we'll go on, I think, and we'll answer the question at the end of the presentation.
You want to move directly to Professor Pascal Jabour, or you want to answer the 5 questions that we have for you guys?
As you prefer.
Okay, maybe let's do that. We have a first question, which is from Dr. Kajan Ranabat and Dr. Bartolini. I think this one was for you. Do you use ACA balloons occlusions to stop retrograde flow? Do you use intra-arterial verapamil to augment anterograde flow?
We do not use verapamil. And the first question was, do we use the balloon to occlude the external carotid artery?
To stop retrograde flow. The external carotid artery, yeah.
Yeah, no, because you have to puncture 2 arteries. I saw up because they did it. I think it's a good technique, but we never did it.
What we do as well, we let the long sheet into the common carotid artery just to avoid to reduce the flow. You can have sometimes vasospasm, especially in babies. And if you push your long sheet into the common the internal carotid artery, you can have vasospasm. So we let the big catheter into the common carotid artery. And if you have vasospasm in the common carotid artery, it will reduce both external and internal carotid flow. So this is not a big issue. But now we stay with our guiding catheter into the common carotid, push the microcatheter into the internal carotid.
Okay, thank you for the answer. We have another question, which is probably for you, Professor Saliou. It's the role of triple drug regimen, MT, carboplatin in the current scenario. That's the question. I don't know if it's clear enough.
We don't use the carboplatin. We only use 2 drugs. Actually, we don't have any guidelines which drug we can use. Maybe it will be interesting to see how the other center treat this patient if they use this drug. We don't have any experience of carboplatin injection in arterial procedure. We only click on melphalan.
May I have can I say something about carboplatin?
Yeah, sure.
Yes, maybe I can answer this question, because in our patient we use carboplatin only when we did tandem therapy. In one eye we use topotecan melphalan, and the other eye, in the same session, we can use carboplatin. This is the regime that our oncologist has made. Probably this is the question of the participant.
Right.
Yeah, Piotr?
In Poland, we use triple therapy in all patients, generally with carboplatin between 20 and 40 milligrams as a standard based on our oncologist experience. So we use it every time. I will show it in the presentation. Probably we don't really know if we need it, because as far as I know, Lausanne uses one drug as a main drug, melphalan. We use triple therapy, and the results are very similar.
Quickly, not based on any data, but initially, 10 years ago, we started using carboplatin, and then we thought that we were seeing more ischemic event in the retina with triple therapy, and then we thought that those babies are sicker with more vomiting and developing more pen hypo platelets and panhypocythemia, as if they are getting IV chemo despite the small dose. So we stopped using carboplatin 10 years ago, and we do mainly melphalan and topotecan depending on the cases, but again, with no scientific data.
Thank you. Professor Saliou, we have also another question for you from Dr. Mohamed Rafik. He says, so you are taking femoral sheath straight to common carotid artery. Which kind of sheath you use? I think you already answered it. and how do you navigate to CCA?
Actually, it's very easy. We use a 3F long sheet. It's a 50 centimeter sheet produced by Balt. I don't know if there is another company who do it, but this one, the 3F, is very easy to use, easy to push because it's straightforward. We use, I use 18 micro wire directly into the this long sheet, and it's easy to get into the right or left common carotid or the vert if you want with the wire, and you just have to push all the way up the long sheet. It's not easy it's very easy to get into the cervical artery in babies. It's a bit different when you want to go in the left carotid of an old people, but in babies it's very, very easy. So I use micro wire 18 directly into the long sheet 3F, and in very rare case we have 3F vertebral catheter. I've never used it, but you can use it as well into this 3F long sheet.
Thank you. We will take two other questions and then we will move to the next speaker. The questions that we have is: do you give heparin in the femoral sheath? If so, how much units? And it's Dr. Satish.
No, we don't give heparin. We give actually not a big dose of heparin during the intervention. It's IV injection once the introducer is in place, and we never inject heparin into the introducer just to avoid any cutting into the femoral access, I guess. We don't do that. Most of the time we have vasospasm. You can have endothelial damages due to the device, and this will be healed by itself after a couple of weeks. And we never check at the end of the procedure when we remove the catheter if the artery is patent or not. This is not very important in babies. Sometimes we can have vasospasm with something, and we think that the vessel is occlusive, but actually after a couple of days the vessel will be fully patent. So no heparin into the femoral access. A few doses of heparin during the intervention. No heparin into the flushing line as well, otherwise you never know which dose you give to the patient.
Thank you again. We have another question, which is: in bilateral cases, do you do in same sessions, or how many weeks of interval? Do you do repeated session for same lesion? What are criteria and interval between session? And it is again from Dr. Rafik.
But we never do bilateral cases in the same session. We just do one eye and then we do the other one. And more or less, the interval is 3 weeks of every chemotherapy. Is at least 3 weeks.
On first line treatment is 3 sessions of melphalan alone. If after 1 or 2 sessions the result is perfect and the tumor is gone, we can stop before. Otherwise, we go up to 3 sessions. And if we have a recurrence of the tumor, or if it remains some tumor, or if we don't have any answer, despite a good positioning of the microcatheterization during the first treatment, we can switch directly to the second line with melphalan and
Okay. Okay, I said we take only 2 questions, but I have another one for you, and then we move to you, Professor Jabour. What is your strategy when you face a wedge arrested flow from ophthalmic artery? Question mark. Keep injecting from ophthalmic or change to external carotid artery? And concerning secondary retinopathy.
Yes, this can happen indeed. Sometimes you can wait a bit, and the antegrade flow can be back sometimes. It's rare. If you have a backflow when you are at the origin of the artery, you don't have any other choice than going more distally into the ophthalmic artery. So you to go more distally, it's very easy if you use the posterior communicating artery because it's straight and very easy to push your microcatheter into the ophthalmic artery. Otherwise, you can try from the internal carotid artery. But what we do now, we try to avoid distal catheterism into the ophthalmic artery from the decum or from the carotid artery because of the increased risk of having retinal ischemia or retinal damages. We don't know exactly what it is. So we first, if we have a backflow into the ophthalmic artery when we are at the origin, we first look into the external carotid artery and try to find an excess. And if we don't find any excess, we do distal catheterization of the ophthalmic artery through the internal carotid artery or the decum.
Thank you. I think we will stop for the questions right now to try to keep the timing. Professor Jabour, if you want to take the floor.
Thank you. I have a quick question. Guillaume and Bruno, thank you for an outstanding lecture. You touched on a very important point. Quick question about involving the posterior circulation. So I think whenever, I have problem involving two circulations, I think that the risk would increase. I want your opinion about the case you showed, about the other option of doing the balloon technique. Do you think the balloon technique compared to involving another circulation would be another option of doing that case?
Actually, we don't have experience of the balloon technique. So we never use balloon, especially balloon into the siphon or into the external carotid. Maybe we should.
Not external. I'm talking about the Japanese old technique.
The Japanese one. I'm always afraid to inflate the balloon in arteries of baby. You have to be very cautious to do that very gently. I think we don't have experience. We are a bit reluctant to use this technique because of the risk of having a dissection, atraurocerebral dissection of the carotid.
Obviously, inflating the balloon carries risk. Is just.
But we don't have experience.
Which one is higher risk? I don't know. Because I'm the opposite. I don't involve the posterior circulation, but I use the balloon when needed, but very rarely. So I don't know. All right, let me share my screen. Can you see my screen? Okay, great. Well, thank you for the opportunity. It's a great pleasure to be presenting on IAC with really world experts that are presenting here in the session. Bruno and Guillaume talked about this. I'm gonna go quickly about that. Something, very important that the cure rate in some areas of the world are still low, and then we still see some mortalities in a lot of areas. So there are a lot of disparities in the world in how retinoblastoma is being treated. So the classical treatment options include all those: enucleation, external beam, systemic chemo. We're trying to avoid all that. And we needed a treatment to first be able to protect from metastasis, because again, we don't want to waste time doing IAC and then suddenly the patient has some metastasis. We need a treatment that is a long-term cure and is able to avoid enucleation, and then maybe is able to preserve or restore vision in some of the cases. So when I think about IV systemic chemo for retinoblastoma in those babies, So it's a little bit like when you're going and buying something online, and then they're gonna be the dispatchers where they're gonna send you know, if the product is coming from abroad, it's gonna come by air, then it's gonna be transported, then dispatched by ground, etc. So it's all this complicated thing until the product reaches the customer, which is the retinoblastoma. When we're doing IAC, it's practically as if we're doing that. Amazon Prime Air. So you click, you order your product, and what happens is it's all streamlined where quickly the product is placed and then it's being picked up by a drone. And the drone flies in directly, and then it would drop the product you ordered 30 minutes ago directly to your doorstep. And here it is. It's very efficient. You're eliminating the middleman, and you're delivering directly the drug. So this is how I see IAC. We started doing IAC more than 10 years ago in Philadelphia, where we see around 50% of the retinoblastoma of the country, of the US. And we've learned a lot since that time, and sometimes we've learned it the hard way. So as you know, the main goal is to catheterize the ophthalmic artery and then deliver the chemo. We've changed our technique the first 2 years, and I'll show you. So we don't use the wire anymore to catheterize the ophthalmic artery. What we do is we pull back, and then we let the microcatheter fall in the ostium. We don't go anything beyond the ostium. Same thing like what Bruno and Guillaume did. They changed their technique and they try not to go distal in the ophthalmic artery. Same thing. We noticed that going distal in the ophthalmic artery is associated with ischemic event. You don't need to go distal. All you need is to go in the ostium of the ophthalmic artery. So the technique that I use now is I don't use any guide catheter. I go with a marathon from the groin up. So always ultrasound. I use a 24 gauge needle to catheterize, and then I would dilate up, and I use the micro introducer kit as a sheath. That's the introducer dilator of the micro introducer kit, and I go with a marathon from the groin all the way up, eliminating any guide catheter. This is my marathon going up, and here I'm going to the right, then going to the left, and then going blindly all the way until I hook in the ostium of the ophthalmic artery. Here it is. I'm hooked here, and this is my super selective run. Then I'm gonna get my drugs, usually melphalan-topotecan. I would inject them over 20 minutes, and then at the end, that's the most important part of the procedure, is groin pressure. I apply my pressure myself. I don't let any fellow or resident do it. Another case showing how we're flipping to the left and going up. The left side can be tricky sometimes. The right side is much easier, but again, going up and letting it fall and hooking the ophthalmic artery. One of the techniques is to puff, puff, puff to go to the left, and then again letting it hook in the ostium of the ophthalmic artery with a little push on it, and then here it is. And then at the end, groin pressure, as I said, is important. If I put too much pressure, I'm gonna flatten the curve. I have a pulse ox on the toe. It's very important, very easy to crush the small femoral artery here. That's why I always go by the pulse ox, and I do it myself. I don't let any fellow or anybody do it, because too much pressure, you're gonna cause thrombosis, and too little pressure, you're gonna cause a bleed. Alternative techniques, we talked about that, about the ECA, or the balloon technique. You see the distal balloon being inflated in cases where there's a stenosis of the proximal ophthalmic artery, where that's the Japanese technique. We just published our cases of, it just came out of the use of alternative routes for delivery. In those alternative routes, we've done ophthalmic artery and the external carotid artery, middle meningeal artery. So we used alternative techniques in 6.4% of the cases. it was 42 cases, 22 MMAs, 20 balloons, no complications in the alternative techniques. Our complication rate in the whole cohort was 4 cases, ophthalmic artery spasm, carotid spasm, and this is in the old technique. So 8 years ago, I switched to the new technique where I don't use any guide. This is a case where there was a 360 loop and I pushed too much my guide catheter. I caused a lot of spasm where I had to stop the case. We had the case of anaphylaxis where we almost did the carotid compression, cardiac compression on a patient. And I had the case of actually a carotid dissection that was caused by the microwire. This was a case that had 6 treatments. It was on my 7th treatment. I had catheterized the ophthalmic artery 6 times. And then with my wire, I caused a dissection just in the dorsal wall of the carotid distal to the takeoff of the ophthalmic artery. The baby did well. There was 30% stenosis. I put him on 24 hours of heparin inpatient, then baby aspirin. There was no stroke, and the patient did well. Those are just showing the cases in our series of alternative techniques where we used 20 balloons, 22 MMAs, and the reasons were unstable catheter position, stenosis of the ophthalmic artery, or occlusion of the ophthalmic artery. Those are the cases where we used the alternative techniques, and this is the alternative techniques that we used and how many times we've used it. So we don't have any cases where we use the posterior circulation. We use the balloon technique instead. And then with the advances with the TRA in adults, I'm a big proponent of transradial approach. This is one of the earliest publications in stroke of our TRA transradial approach in adults. And then we moved and start doing TRA when possible in babies. Again, not a lot of babies, there are some indication. I'm gonna show you this. This movie was published in JNIS. It's already, my voice is already recorded, so it's not live, my voice.
Retinoblastoma is the leading malignancy in the eye in children. And the abnormality cure rates can be as high as in developing countries. It can be retinal from A, the femoral artery or radial artery are accessed with a 24 gauge angiocath with ultrasound.
So this is what I use,
and
that
then
this
dilated
24
up
one.
to the 4 French micropuncture kit introducer that's used as a sheath.
That's
for
what I use
patients
for the sheath.
that are above 3 years old, we do the transradial approach. For patients between...
So my limit is 3 years old for transradial. 3 years to 10 years, I do marathon from the wrist up because I cannot fit a SIM4. And 10 years and above, I can fit a 4 French prelude sheath in the wrist, and then I can, at that time, use a
10 years old,
marathon.
We use the 4 French micropuncture kit introducer. Then a marathon and synchro 10 is our first choice. We will go from the wrist all the way up to the ophthalmic artery. In case of failure of the marathon to track, at that time we use the Prowler 10. For patients above 10 years old, we would fit a 4 French prelude sheath in the radial artery, and we would use a 4 French SIM2 to hook the proximal common carotid artery, then a marathon all the way up to the ophthalmic artery. For patients less than 3 years old, we use the transfemoral approach with a 4 French micropuncture kit introducer and a marathon and synchro 10 introduced into the diaphragm of the sheath from the groin all the way up to the ophthalmic artery. We let the tip of the marathon fall in the ostium of the ophthalmic artery without using the micro wire, and then we would do a micro run to check for stability and for reflux. We use Malphalan or Topotecan. The dose depends on the size of the tumor and the grade, and it's given pulsatile with manual injection over 20 minutes. And it's average 2 to 3 sessions per baby, separated by 4 weeks. If the ophthalmic artery is occluded, we can use the middle meningeal collateral to the ophthalmic artery to deliver the chemotherapy. Dilated up is going all the way before retinoblastoma. It's radial
so
approach
this is
for
my radial approach.
chemotherapy for retinoblastoma. The
That's
radial
the
artery was accessed
Prowler.
with the introducer of a 4 French micropuncture kit. Then a Prowler 10 and Synchro 10 was navigated all the way from the radial artery all the way up to the internal carotid artery. Then super selectively, the ophthalmic artery was catheterized and the chemotherapy was administered. This baby got 3 treatments and was
Here
cured
it is
completely.
hooking the
This movie shows a case of intraophthalmic artery cyst.
This is the
Then
wristband.
the sheath is removed while the TR band is being inflated.
Okay. So this is in the older kids above 10 years old. That's the SIM 4 French SIM. I would catheterize just proximal, the common only, and then I would go up and again do the same technique. This is another case of going up all the way from the wrist. In this case, the Prowler was herniating. I had to go up with a Marathon because it was herniating in the arch. This is going up. This is from the wrist with the Marathon. We need to be careful. If we push too much, it's going to herniate at the arch. And then here it is, distally up. I'm advancing, then pulling back, let it fall, and then give it a little tug. And here, there's some reflux. I'm going to talk about reflux. We don't worry a lot about reflux. This is another paper we published about IAC via the transradial route. And it makes sense, really, those babies, instead of putting them 6 hours sedated and everything, they can really walk home right away, and the family is happy, and the kids are happy. This is some of the cases of retinoblastoma, 2 doses of melphalan before and after, group E, regression at 4 years with 5 doses of melphalan. This is one of the earliest, papers that we've published showing the result of IAC on tumor control, 85% all over, all grades. On the subretinal seeds, 82%, vitreous seeds, 67%. As you see, if we go by groups, CD had really high tumor control rate, E is lower. Secondary treatment after failure of IV chemotherapy, around 50%. One of the earliest series that we've published about some complication, forehead erythema, we see it a lot if the chemo is going there. Ophthalmic artery occlusion, we had, when we first started, around 5%. Choroid vasculature reduction, around 15%. And we've changed a lot after that, and I'll tell you what we did. It's a little bit like our colleagues in Lausanne, what they did. So a lot of microischemic changes. This is the fluorescein angiographic findings after intraarterial chemo. So we've seen, vascular pruning in the choroidal vessels and the ophthalmic artery. And as you see here, that's the normal perfusion. That's an ophthalmic artery occlusion. This is a retinal artery obstruction, atrophy of the choroidal arteries. And we looked at enucleated eyes. And at the beginning, we started seeing birefringent bodies by looking at that. So you see here, and then those were some synthetic and cellulose fibers. So again, we don't think of it in adults because we go into large vessels and it doesn't matter. But when you're catheterizing a small vessel like the ophthalmic artery in babies, you need to think about every single detail. So we stopped using any linens at all, and we start draping everything with Ioban all around the patient, and this also decreased a lot. So what the effect on retinal detachment, this is another paper. As you know, initially when we started doing IAC, we didn't do it just for the reason to restore vision, but mainly to avoid enucleation. but we've seen that in patients with the retinal artery detachment, if they respond, we saw some restored vision in partial retinal artery occlusion in 100% of those cases if they reattach, in complete total retinal artery detachment in around 43% of the cases. Those are cases of total retinal artery occlusion and partial retinal artery occlusion. So when the tumor shrinks down, the retina will go back, and those patients are able to restore the vision. Another paper we've published showing in the results according to the group ABCD, same thing. Best result in BCD, B, C, and D. We've treated extreme ages. This is a patient 32 years old that we treated with anti-arterial chemo for retinoblastoma, and really tiny babies of 2 months old. Primary versus secondary. This is a patient of primary retinoblastoma that showed really good results. Secondary treatment was patient that had recurrence after IV chemo. Again, I think this should be a tailored procedure, a tailored treatment. We have so many ways of treating it. We're only involved in that, but the ophthalmologists have a big armamentarium of how to treat that, and it's very important to know when to treat that. We've had patients that responded to only one treatment. This is the baby with the 13q syndrome that responded to one treatment and is still cured. So yeah, in general, we do 3 treatments, but we've had cases where we've done only one. We've had cases where we've done much more. Ophthalmic vascular events after retinoblastoma. This is a very important slide. You see our complication rate of the vascular ophthalmic complications, how it decreased really. And now we're really very, very low complication rate. And this is because we've changed a lot of things. We've changed the way we drape the patient. We've changed the way of how we advance the microcatheter. We don't advance it anymore in the ophthalmic artery. In all the cases, all we do is just the ostium of the ophthalmic artery. If I have to I have to advance it, or there's a stenosis, I'd rather go external or do a balloon technique to prevent that. We've also changed our technique from not using any guide catheters anymore, and we're using the microcatheter from the groin up. We looked at ophthalmic vascular events for primary and secondary treatment, and there was no difference between primary and secondary treatment. For the people that are worried about IAC, that we're missing mets and there's a problem with the systemic disease, well, this is a collaboration that we did with different major centers in the country, and showed that really there's no deaths from no metastatic disease, less than 3%. There was 3 metastatic deaths that was in South America, but the rest we've never seen any metastatic deaths using that. Earlier, Bruno talked about the reflux. We looked at our reflux, and initially we were very obsessive about reflux and that we shouldn't have any reflux. Well, we just published this paper on, we looked at our reflux, if the reflux affect tumor response. A lot of times we spend time to try to avoid reflux. I think spending time and trying to advance the microcatheter carries higher risk than accepting some reflux. I know we're all obsessive people, we want perfect imaging, but when we looked at our series and the reflux, again, this study has a lot of limitation. How you gonna quantify reflux? And when we do multiple treatments, there are patients that have reflux on one treatment, then the second treatment no reflux, then the 13th has reflux. This is why we classified them between reflux, no reflux at all in all treatment, or reflux on every treatment, or variable reflux. And there was no difference in tumor regression. There's no difference on enucleation rate on all those patients, as you see here in all the tables. So again, I think a little bit of reflux is okay. Of course, if you don't see the ophthalmic artery at all, definitely not. But if you see the whole ophthalmic artery and you have reflux, regardless of the amount, I think this is acceptable. More recent paper is going to come out soon in AJNR about babies less than 10 kilos. It used to be a contraindication. I don't think it should be. We've treated babies like in the other centers that are less than 10 kilos, and even babies that are less than 4.5 kilos. So definitely it shouldn't be just a contraindication. It should be case by case. In those babies less than 10 kilos, those are cases where, yeah, we've aborted procedures because of access, but when we brought back the patient a week later, we were able to go in. So those are the highest risk of aborting the procedure, but aborting it doesn't mean not doing it. We bring the patient back in a week and then we're able to do it. We kept on doing IACs even during the Corona times. As you know, we stopped all the elective cases and we classified cases by tiers. Despite the fact that this IAC doesn't belong to any tier of emergencies, but those are babies that can lose their eyes if we don't treat them. That's why when we stopped all the elective cases, we kept on doing IACs, and we did IACs while wearing the pampers, and this is how we were doing them in style. So again, IAC opened the horizon. I think I never thought when I went into neurosurgery at the beginning that I would be involved in treating an eye pathology, an eye disease, but I ended up getting involved in that, and I'm happy I did that. You really have, start having friendship with the families, with babies. This was on the Sunday cover of the newspaper, the Philadelphia Inquirer in 2009, about the baby I treated. This baby was barely 6 months old. So right now the baby is 9 years old, and now we're friends on Instagram. And this baby that you saw there chats with me sometimes on Instagram, and here he is. He's like, "Hey Ty," he's like, "Hi. How are you? Good. How are you?" He's talking to me. It's like, "I had a basketball game today. I scored 2 points." I was like, "Wow, it's awesome." So it's really nice to have those babies grow up. All the families are really grateful families, and it's great to see that we're able to have a difference in outcome. I'm gonna finish by saying it's fun to work with babies, and the French-speaking people will understand that move.
Papa. Maman. Allez, dis papa. Maman. Dis-le, ou c'est papa qui boit ton biberon éveil. Papa. Maman.
Mais qui a fait ça?
Papa.
Thank you.
Professor Jabour, thank you. Great talk. We do have a few questions. The first one is for all the panelists. Do all physicians in the panel do the AACs in group D and E only? Role in group C disease?
No, I do it in group C, and as a primary treatment. And again, avoiding IV chemo is really important, I think. And as I showed in our papers, the response rate is very high. The complication rate of our procedure is low, and no, it should be done in C.
Okay. Then we have a
question. Do you want to? I'm interested in hearing the rest of the speakers.
You didn't do any intrathecal chemotherapy in group A and E, in both extreme of groups.
So you do B and C?
Yes.
Yeah, absolutely.
We do group D, and for the other group, it's very rare. Our physician, as we never prove that intrathecal chemotherapy is better than IV or the other or local therapy. So we only do group D, and not only, but very rarely the other groups.
We do up to D. We do D, C, D, mostly, right now, mostly C and D.
Yeah.
Okay,
don't you guys think if it's non-inferior, it's worth it to avoid IV chemo?
And maybe. Hey, we don't know. Hey, if you manage to prove it, we will be
Yeah.
Be very happy. Yes.
I mean, of course, we all have our own biases, but I mean, this is
Yes.
a low risk.
These are
effective-
very,
What?
we are oncologists, pediatric oncologists, who are very cautious with all treatment. So they are confident with what they are doing now, and to change, we simply just to prove first.
Yeah.
Thank you. Professor Jabour, I think this one is for you. It's from Dr. Francisco Montalverne. It was not clear when you decide to use radial approach for intra-arterial QT or retinoblastoma. Could you please clarify?
Yeah. So I'm going to clarify that patients that are above 3 years old, I would use the transradial approach. When it's from 3 to 10 years old, I cannot fit a 4 French prelude sheet in the radial. It's too big. In those cases, I would do the introducer, the small introducer as a sheath. I use it. And then I would go with the marathon all the way up, knowing that only for the right side, because I'm using just a marathon, and it's very challenging to go with only a marathon transradial to the left side. So those cases I use transradial. Above 10 years old, always transradial, because in those cases I can fit a 4 French SIM2, and I can treat right and left. Anything less than 3 years old, I use transfemoral.
Thank you. Then we have a question for the whole group from Dr. Farouk Hassan. In your multidisciplinary protocol, do you use IA, chemotherapy as primary treatment, or just in bilateral disease or failed case with other approaches?
Again, I think I'm the extreme in the panel here. And it's good to see different point of views, but as the extreme, I mean, we are fighting for IAC to be primary treatment. I mean, IAC as a primary treatment should be the way to go.
We use IAC.
Sorry.
No, sorry, you.
Okay. In Poland, it is generally primary treatment, as for most of the patients, intraarterial chemo goes as first-line therapy for all the patients that can be cured, because we haven't gone under 5 kilos yet. And I'm saying yet because I think it's possible, but we haven't done it.
So we do in Argentina primary treatment in BC and sometimes in D. And I agree totally with Pascal. It's better intraarterial chemotherapy than intravenous, always.
We also use it as a primary treatment, but most of our kids, they come from abroad. And in these cases, normally they already had the intravenous treatment in their countries, and then they just came for the intraarterial system.
We only have maybe one case from Switzerland each year, so it's a very small country, and actually all our cases are from abroad, and already had local therapy or IV therapy.
We have a last question, and then we can move to Dr. Rekeroto. What findings in EUA make you decide the numbers of IAC sessions, in particular in babies?
So I'm not involved in that. I'm just the surgeon doing what Carol Shields, my world-renowned ophthalmologist, recommends. So, I mean, obviously, she has criteria about recurrence, about how much the tumor is shrinking, to decide how many treatments we still need to go. But I don't argue, I just do the case.
And just a few words about reflux. We totally agree with your experience, Professor Jabour. It's not very important if you have mild reflux. We had very good results with some reflux of the drug into the carotid circulation. So don't pay attention too much to that. If you have some part of the drug who is washed into the eye, it will be enough to have an effect on the tumor.
Yeah, and the problem is when you try to avoid this reflux, this is when you run into trouble, because I have a lot of people from all over the world contacting me. And the reason I decided to write this paper is because I've seen cases where they would show me, it's like, well, we had this, we had to stop. I was like, you had to stop? It was perfect. Why did you stop? Or other cases where we tried to go in, we went in, and then we had a dissection of the ophthalmic artery. So I'm glad that other people agree with me that really don't pay attention to that.
It's a mistake we can do when we begin with this technique, to try to go deeper into the ophthalmic artery, and if you do that, you will have some spasm, and the procedure is done. You just have to remove everything, and you didn't deliver any drug. So it's better to just try it first. What we do when we have a reflux, we always tell the ophthalmologists that, and the oncologists, that we had some reflux. Tell us if we expected a good result and we didn't have a good shrinkage of the tumor, and we will see the second session. But the first time we always try like this, and most of the time we have very good answer.
Yeah. And I've learned a lot the hard way. I mean, my first year, 10 years ago doing it, I still remember I was trying to straighten a internal carotid loop to go up and have support to be able to catheterize the ophthalmic artery. This is the only case where I had bad, terrible spasm, where I thought I dissected the ICA, and then I had to abort the procedure, inject calcium channel inhibitor, which, you know, we've learned. I mean, you don't need to do that. And as you said earlier, in those babies, a lot of times you have carotid loops, so this shouldn't be an issue.
Yeah, I'd like to back up, because a few years ago we were too much obsessed about the reflux, and with time we thought, okay, to some extent it's okay. If it's not a retrograde flow, we should do it. In most of the cases, we shouldn't care about the backflow. So we share the same opinion.
Yeah.
Yes.
Then I have 2 extra questions before we move to the next talk. Dr. Jabour, this one is for you. Pascal, do you perform an ultrasound follow-up on radial and femoral arteries of these babies? This is from Adrien Guénégaud.
Yeah, I do not perform any follow-up ultrasound on those babies. I just do an ultrasound before the procedure right away, and I haven't had any radial artery occlusion or anything.
And then we have a question for the whole panel from our friend from Mexico, Christopher Mader. So speed of infusion, still 1 milliliter per minute, or have we moved onto faster speeds?
It's 30 cc every drug. I inject every drug in 20 minutes, so a little bit faster than 1 cc per minute. I do 20 minutes per drug. I don't know the rest.
Yes, sometimes 20 or 15 minutes too. 30 minutes is too long time.
I agree.
Too time consuming.
Yeah.
Yes, but we deliver the drug between 20 and 30 minutes.
Yeah.
Actually, we don't know. Maybe we should go faster. We don't know.
Yes, I think so.
We go something around 10 to 12 minutes per drug.
I like that. I'm gonna adopt that.
Okay. Thank you for your talk, Professor Jabour. Dr. Requejo, if you want to share your screen.
So it's good. It's nice to see.
Perfect. We can see it perfectly.
I would like to thank the BALT team, and for me it's a great pleasure and honor to share this virtual talk with my colleagues from all around the world. I'm Flavio Requejo, and I work in Argentina, in Buenos Aires, in the Garrahan Hospital. It's a pediatric hospital. And I would like not to repeat the other concepts, but I go ahead. The most common finding is in retinoblastoma, as you know, is leukocoria and strabismus. And imaging findings, the first imaging is the ultrasound, then the fundoscopy with RECAM, and the MRI is especially important not only for the diagnosis of the retinoblastoma, but to rule out cerebral metastasis. And as other colleagues have said before, this is an enhanced tumoricidal potency with a high concentration, but using only 10% of dose of systemic chemotherapy with fewer systemic toxicities, as Pascal has said before. So the goals of the therapy is salvage of life first, ocular glow, and when it's possible, the vision preservation. The history is, I would like to add the first one. In 1954, Rees injected an hydrogen mustard analog in ICA by direct surgical observation. And then the other colleagues have said the Japanese technique and the technique that we are using today all around the world, performed by Pierre Gobin. This is a multidisciplinary approach. In our hospital is a referral center. The first physician that received the patient are the oncologist and ophthalmologist. They do diagnosis, the classification, and the indications. And then we receive the patient with the anesthesia, and we, the interventional neuroradiologist and anesthesiologist, with a team to study and to perform this procedure. That is very important, the anesthesiologist in our team. And other people are involved in this field, pharmacy, genetics, laboratory research, animal research area. And this is the international classification. As I said before, we did group B, C, and D. In group is a local therapy, and in group E, in our hospital, the patients are enucleated. We started with this technique in our hospital in 1910 by another physician, and I started in 1914, and with 89 patients and in 97 eyes. We did 8 standard procedures, and in total, 11 and 12 procedures. This is a little bit, we have higher procedures than per patient than other centers. Our youngest patient was 5 months old, and the oldest was 5 years. Most of our patients have 10 to 25 months old. So we have other entities in this age, as vein of Galen aneurysm, dural fistula with dural sinus malformation, and PL fistula, and AVM, a little bit older patients. As I said before, we have a higher number of procedures than other centers, and this is the indication of the oncologists. We have nothing to do with these indications. We did the procedures. The drugs we are used are topotecan, melphalan, and carboplatin in the tandem procedures. The key points are that we are treating young children with tumor, and it's important to decrease the fluoroscopy time, because young children with tumor are prone to develop second cancers with X-ray, even with the diagnostic purposes. They have multi-procedures, so we have to decrease the fluoroscopy time and use catheters as more as possible. And it's important the size of femoral artery, because if we injury femoral artery, probably is in the beginning asymptomatic, but when the patients reach the teen age, probably he had claudication on either limb growth, poor limb growth. That is very important to take care of the femoral artery. And the last point, very important, is to get the choroidal blush. That means that the drug will reach the retina. The technique is very simple, and we puncture the femoral artery using a 3 French introducer, and we navigate a magic 1.5 microcatheter from the femoral artery to the ostium of the ophthalmic artery in order to use the smallest catheter possible to avoid vessel damage. The ophthalmic artery is selective as when possible because it's the best route of administration. As I said before, we use the low fluoroscopy time. This is our introducer needle. We use frequently a long introducer, so as the Lausanne team, because we found very, very useful this long introducer. Use a femoral approach because our children are very, very young, between 10 and 25 months, most of them. We use always plastic rope to avoid the unwanted migration of cotton, as Pascal has said before, has shown. Use ultrasound guidance to the puncture, and use obviously general endotracheal anesthesia and heparin. We navigate from the femoral artery to the ophthalmic artery, and here is we puncture the left femoral artery, and this is a magic microcatheter to the right ICA. As Dr. Jagour has said, we did a blind navigation when it's possible. And use the jump technique, that is using the different forces between ICA and ophthalmic artery. And here we get a nice choroidal blush. This is the most technique. In most cases, we use whenever possible the ophthalmic artery in 83% of cases. And we use the clinoid because we use a landmark in order not to give a lot of fluoroscopy, just to control the position, the stable position of the microcatheter. And sometimes the position is not stable. So in the first years, we use a guide catheter, a 4 French guide catheter, a Fargo Mini. But then we discover this long introducer, 50 centimeters, and it's very, very useful to us because it's a small one and gives support to the micro catheter. It's very easy to ascend. We use first an 18 guide wire. And we select in this time the left common, or here we select the ICA. But I agree with the Lausanne group that sometimes it's better not to ascend to distal than the introducer. The introducer has the advantage that it can use as introducer as well as a support catheter. And when ophthalmic artery cannot be reached because of dorsal origin, or the ostium is small, or the small the ophthalmic artery, or there is vasospasm, or even the ophthalmic artery is reached, but the choroidal blush is not very nice, we use the anastomosis, as sometimes the sessions are different. One session is different to the other. I mean, in one session it's very easy to reach the ophthalmic artery, and in the second session it's impossible, probably because of temporary variance in hemodynamic forces between the external carotid and internal carotid artery. So we use the anastomosis and mainly the middle meningeal artery anastomosis with ophthalmic artery. That is in 16% of the cases about, and here we say the anastomosis and the flow of the middle meningeal arteries is goes to the ICAs, to the ophthalmic artery. Here this a direct anastomosis between the middle meningeal artery and the ophthalmic artery, and here the lacrimal branch of the ophthalmic artery. But there is other anastomosis, supratemporal, angular artery. And when these anastomosis are not available, we use the third option. We use balloon. I prefer personally use a balloon that catheterize the posterior communicant artery, because we involve two circulations. Sometimes it's a little bit dangerous. The problem with the balloon is that we have to use 4 or 5 French introducer with the femoral artery injury potentially. We have to inject drug a little bit faster with potential retinal damage, and we can did some ICA dissection or thromboembolism with the balloon. This is our case. With a tandem therapy, the first sessions were uneventful in both eyes. The second session, we were not able to reach the ophthalmic artery because of it was very, very small. We can have a good choroidal blush in the anastomosis, so we decided to use a balloon in the distal part of the ICA, and this is the injection of the contrast. So the complication is similar than other authors. Retinal hemorrhage we had in our patients, alopecia, transient femoral artery. That was the time when we didn't use ultrasound. Hypotension, bradycardia, and desaturation is probably a reflex that is very, very common to have, anteroocular edema. Some complications related to the drugs are emesis, allergies, anaphylactic shock, fever, neutropenia, and thrombocytopenia. This is the case with alopecia. We choose the superficial temporal artery, probably was some reflux. And this is the case of retinal hemorrhage, as the authors said before. This was because we navigate the microcatheter distal in the ophthalmic artery, and probably the injection of the drug on the fluid caused the damage of the retina. Our conclusion is the technique is effective and safe. It's very important to get a choroidal blush, because if you have a choroidal blush, it means that the drug will reach the retina. It's very important to use small size catheters, maintain low dose of X-ray, and is a technique with a low rate of complication. Thank you very much.
Thank you, Dr. Requejo. We do have a few questions. One of the questions which is coming back quite often is, do you filter melphalan? This is for everyone, I believe.
No, we don't.
I don't.
We do. One of the changes we've done after we started having, when we looked at the slide I show about the pathology of the eye, is the crystallization of the drug, possibly a cause also. So we started filtering it.
In Poland, we don't filter. We use 30 minutes time after production of the preparing of the drug. Our pharmacy says that it's safe, and we take into consideration. We checked few different Malpalon produced products, and they vary in solubility. Some dissolve in water very well, and some don't. So this is something that we just take into consideration with choosing the Malpalon.
Thank you. We have another question, which is from Dr. Fausto Ferraz. When using balloons, how long is the drug injection and time of balloon occlusion?
I take no more than 5 minutes in the injection of the drugs. That's the reason the drugs are faster injected than the classical technique.
Okay.
Same here. We injected very quickly, and we do neurophysiologic monitoring also.
Okay. Then we have 2 questions from the same doctor, Dr. Farouk Hassan. Do you regularly put vasoconstrictor nasal drops before drug injections? And the second one, I think you already answered, but it's concerning the balloon, and I'm gonna read it. In case of balloon technique, for how long do you inject the drug? I think this one is answered. And do you inflate, deflate the balloon in between?
I don't inflate and deflate the balloon in between. I did as fast as possible, and I don't use any drugs in the skin.
Dr. Jabour, you have a comment on the balloon, or?
I don't deflate the balloon, same thing, and I don't use vasoconstrictor. I know the New York team, they use vasoconstrictor.
And we have also on balloons a question from Dr. George Yassa. What kind of balloon is used?
I use regularly eclipse balloon, I think 4 millimeters diameter.
I use a hyperform.
The problem with balloon is we have to use some guide catheter, and mainly a 5 French guide catheter, and that is a little big. Is bigger to use in the small femoral arteries. This is the problem of the balloon. I had no bad experience with balloon, but the background, the using balloon, the problem I think in small children is the introducer. We have to use 5 French introducer.
Okay. Thank you, Dr. Varekejo, for your talk. And I think we can move to the last talk of the day. Dr. Rago, if you want to share your slide deck.
Dùng đi bảo vệ đề cương. Dùng đi bảo vệ đề cương đấy.
Okay, my name is Peter Rago. I represent the Polish team, and I would like to thank Bob for inviting us to this wonderful meeting, and especially Frederick Powiecki and Natalia Markiewicz, who thought about us and put us in line with such a great name. In Poland, we are running this program for 5 years. We started in 2015, and in this time we made over 250 procedures. But the last years we make around 60-80 procedures a year. I'll try to focus on things that probably were dropped out due to lack of time, and focus on some key points that might be different between all of the centers. At first, we need to remember that this is not a standalone therapy, and we need a full team, retinoblastoma team, including oncologists, ophthalmologists, good pharmacy with good contact, genetic specialists, and anesthesiologists that can be aware of everything that can happen during the procedure. And of course, this is not the only treatment, it's just a part of the treatment. We might be the first line, we might be the main striking force of the treatment, but without the whole rest, including cryo, laser therapy, intravitreal, the whole procedure doesn't make any sense. I don't have to convince you that the results are very, very good, and you all know that. That's probably we have such a large number of attendants. But we need to start with the anatomy that was quite well said before. We have the internal carotid artery, we have the ophthalmic artery, anastomosis, which with the meningeal media, which will be our second line choice. But we also have other things like supraorbital skin branches, and sometimes small branches to the nasal region. And answering the question that was already asked, for those patients, we use cold compress on the forehead, and we haven't had any skin necrosis since then. This is more than 3 years. Before it happened two times actually, and we use xylometazoline intranasally to avoid damage to the nasal region vessels. This is the anatomy that you have seen many times during this presentation. Of course, we have an ophthalmic artery, the anastomosis is with meningeal media, and something that we want to see all the time. We don't care really about the reflex. It's something that, okay, if it's very, very big, or if we have a retrograde flow, it matters. But the main thing that we need to see is the choroid blush. In our practice, we use a set with Vasco 35D as the leading catheter and Magic 1.5 with no wire. That's the same that we heard today. We just go with the Magic itself from the C2 level up. Magic is very delicate and very flexible, and it's a flow-dependent catheter. So in most cases, around 50%, it will lock at the ostium by just going up. In the rest, it will lock on the pullback. For the secondary choice, we use sometimes Magic 1.2 and in some selected cases Vasco 10. But we used maybe it 4 times last year. As a chemo, we still use the 3 drug therapy, including those drugs in this particular lineup. We want to give the melphalan first, and the range of the dosage is between 2 and 5 milligrams. Most of the patients right now get 4 milligrams. The second drug, carboplatin, and the third drug, topotecan. Historically, we used the dosage between 0.3 and 1. Most of the patients right now go with 1 milligram. All the drugs are dilated to 7-10 milliliter pure saline. We don't use heparin to solve the drugs. And of course, the drugs combination were modified with bilateral retinoblastoma. We did tandems in the past, but we aren't sure if this is effective. So we tend to go for one eye, as colleagues from Lausanne said, then trying to cure both eyes at the same time. And the heparin dosage is 50 units per kilo intravenously. In the past, we used 70, but we have a lot of hematomas and extended bleedings. We dropped to 50 units per kilo. There was a question about filtration. We don't use filtration. The filters aren't available in Europe, or we haven't been able to buy them. We use a time period of 30 minutes after preparation. So we order the drugs at the start of the procedure with the patient on the table and try to do it within 30 minutes. And we have to remember that different melphalan products had different solubility. We tried Medirena, which dissolved very, very poorly in water. And right now we use mostly Aspen melphalan, which has a very high solubility in water, and we haven't seen crystallization at any point during last few years. And of course, the standard is 3 procedures in a 4 weeks interval, but there are some patients that get 4 procedures or even 6 procedures. This is our chemotherapy set, and why I'm showing it for particular reasons. I know that some centers tend to go with 1 syringe and giving the chemo from the 1 syringe. We state that double syringe and the chemo in the bigger one, and pushing with 1 milliliter syringe is better. It gives you control over the speed, pulse volume control, and in many cases you can feel when it locks out of the ostium, of the ophthalmic artery. If it go out, you will feel it on the 1 milliliter syringe. And with time, with every drug, you will feel if it fell out, or you will feel the higher resistance where you get a spasm. That's something that we think is good. For the technique, we go, as Professor Jabor said, we go blind from until we get the ophthalmic artery, and it's the reason why we have a very low radiation dose. The lowest in the history was 2 milligrams and 32 seconds of fluoroscopy. The mean is around 3 to 6 minutes and 4 to 9 milligrays, but we use very low scopy radiation. Contrast volume in a standard procedure, when we don't go through the meningeal media and we go just straight to the ophthalmic artery, is under 4 milliliters. Of course, there are situations like bilateral retinoblastoma with double meningeal media approach, when the dosage was, of course, much higher. The age of our patients are from 4 months up to 7 years, and the lowest weight was 5 kilograms in our practice. For selected patients, we use cold compress on the forehead. If we see big branches going for the skin of the forehead, and intranasal stilbene, but it's not the standard. It's not something we do every time. And to focus on how we do it, I will go through the standard procedure and our choices, how we make it. We make a femoral access with a 4 French introducer. With smaller children, we use Terumo Slanger because of the low profile, but we're starting to use the EVA 3 French introducer as well. We're fixing the Vasco 35D at the C2 level, and with constant rising with heparin saline, we go forward with a magic itself. Until last year, we had a standard that we always did an angiogram from the carotid to see if the ophthalmic artery is there. But right now, we really think that we don't need it. We just go with the magic itself, with the flow, without any wire. When it locks at the ostium, we make a angiogram to confirm that the placement is okay. This is a big anastomosis, but we have a choroid blush, so we thought it's okay, and we went on with the procedure. In most cases, it will look like this, with a nice blush over here. But if we're not sure, before we make an angiogram to confirm, we just do it on the fluoroscopy to check if we have a big reverse flow to the head. And after that, if you want to reposition or find a better angle, we try to do it as fast as possible, because we don't want to stand there too long. We think that as longer we stay at the ostium, the worse the results are, because of the spasm, and we can have some ischemic complications. This is the typical view of what we see before we start administration drugs. And something that we are a little bit obsessed about is contact between chemo, heparin, and contrast. In the early days, we had some issues with after contract, and we connected it one TIA that we had, and some complication in the early days of the procedure with the contact between melphalan, heparin, and the contrast. So right now, we always change syringes and flush with pure saline. So we go with pure saline to flush out the contrast, go with melphalan, pure saline, change the one syringe, go with carboplatin, flash, and again and again. And I'm showing this set again one more time because we think that in some cases where you have the leak to the head or or intracorrodal leak of the contrast, you can adjust the good administration just by changing your pulses and the speed of administration. And I will show a case at the end. Why do we think so? Of course, this is the situation when you can see the branches to the forehead and the branches to the nasal region. And this is the case which we would use both the cold compress and silomeprazole as a standard for this patient. Of course, there will be cases when going through the standard way to the ostium of the ophthalmic artery won't be achievable because of the retrograde flow or anatomical reasons. And our second choice approach is always the meningeal media approach. We're looking for the anastomosis from the anterior branch of the meningeal media. Of course, in this case, we take a wire. Our choice is hybrid 07. I know that most of you may think about 8 episode. I'm not sure if I'm right, but we like the hybrid 07. This is a typical anatomy with meningeal media, posterior branch, anterior branch, anastomosis, and the reverse flow to the ophthalmic artery, and the AP view, and the typical angiogram after administration, but we don't have a blush here, so we made a second one. We have a blush, and we have a quite big backflow to the head, to the carotid artery. Let's back to the slide. We adjust, made smaller pulses, and we don't have it. We have a beautiful choroid blush and no backflow to the carotid artery. Our second choice, because in some patients we won't see the anastomosis, or the anastomosis won't be enough. It will be composed of a very small vessels, and it won't be possible to find a decent way of adding. Direct catheterization of the ophthalmic artery, so going in, is our third choice. Of course, the risk of spasm, ischemia, and other complication is much higher when you go inside the ophthalmic artery. This is the case right now. Of course, you can see the magic on this. Magic will look like this. The effect was very, very good, but in that case, you don't want to stand there very long. The whole procedure, we think that the whole procedure should last as short as possible, and you should proceed with the drugs quite fast, if it's possible. Not to stand at the ostium, because originally, a few years ago, we tended to order the drugs when we reached the ophthalmic artery. And the effects were very, very poor, really, because when we stood there for 20 minutes, most of the cases, the ophthalmic artery got at least a little bit of spasm. Oh, I skipped something. And this is the patient with the direct ophthalmic artery. And we have a coronal blush, so it's okay to deliver drugs. And of course, we have to have in mind that there are other ways of achieving it through the posterior circulations. we don't do it. We are a little bit afraid of going through the vertebral artery. And of course, the balloon technique, we haven't done it for the last 2.5 years, but historically, we used it. We got better with the meningeal median, really. And that's when we stopped using the balloons. Because the units per kilo heparin, right now it's it doesn't happen very often. But hematomas and elongated bleeding happens sometimes after the procedure. During 5 years, we didn't encounter any serious complication. The most serious one was 1 TIA in the early days of our practice, and 2 skin necrosis. This is why we started to use cold compress as a standard for selected patients. That's something that I wanted to tip out is within that full retinoblastoma team, we need a constant communication. We have communication with many levels with all the team, oncologists, ophthalmologists, and we are online all the time between communicating with each other and talking with each other. And communication language, I remember it was shown in one of the presentations that you reported the reflux as reflux, maybe reflux or no reflux. We have a 3+ scale that we use. We just say, our colleagues, ophthalmologists, okay, there was a reflux on 1+. That's a very small reflux. And this is our team. Dr. Bartuszek, my right hand on the left, me, and our youngest resident, Paulina, on the right. Thank you for your attention. If you have any questions or something you want to discuss about, I will be pleased to answer them.
Dr. Rago, thank you for your talk. We do have few questions here. From Dr. Farouk Hassan, when you use melphalan with topotecan, do you put them together on the same amount of saline, or you inject them successively?
No, successively. You go with melphalan, flush with pure saline, second drug, flush with pure saline. This is what we do.
Okay. Then we have another question from Dr. J. Bay. Direct ophthalmic access with surgeon or only percutaneous under ultrasound? Question mark, and then safety.
We use ultrasound to obtain access in most of the cases, and especially the smaller children.
Okay. Then we have a question to all panelists. To all panel, in some case, reverted the heparin with protamine. Do you recommend it? Question mark.
We haven't done it. We didn't have to do it.
We don't do it.
We can't hear you, Dr. Requejo. Your microphone is switched off.
After compression, after 20 minutes compression, if there is some bleeding, then we revert heparin. It's the only reason.
I actually use it every time, so I give 1 milligram per 100 unit given of protamine.
Thank you. And another question for all of you, I believe. I have had severe bradycardia cases at the end of the procedure, which we believe is by protamine. It's a question from Dr. Miguel Bedrinana. Sorry if I don't pronounce it correctly.
We haven't.
So, I mean, I give protamine all the time, so it needs to be given really very slowly, and they give it over 10 to 15 minutes. So I start pressure while sometimes they are still pushing the protamine, and we've never had that. Now, bradycardia and DSATs mainly happens also when you catheterize the ophthalmic artery ostium as a vagus response. And that's why the anesthesiologist will always pre-treat everyone with bronchodilators. And we noticed that this happens mainly in the second treatment, whenever you're trying to go in the ophthalmic ostium of the ophthalmic artery, and mainly in small babies, you have this response where you have hypotension, bradycardia, and DSAT.
Okay.
So that is the reason it's very important to have the anesthesiologist with good expertise in this technique. The anesthesiologist must be aware of this reflex, and he or she must pay attention during the procedure.
Thank you, Dr. Lecker. We do have a question, which is from Dr. Prieto. It's for those of you who are using balloon. Don't you prefer to use a balloon at the ECA instead of ballooning ICA?
Well, the reason I use a balloon is not because I have a problem with the competition of flow. The only cases I use a balloon when the ophthalmic artery is too small, or there's a stenosis at the ostium of the ophthalmic artery because of many treatment, and when I don't have any good MMA collateral. This is the only reason where I would use a balloon.
When we use balloons, we didn't use it for externa, because if you have a reverse flow, you probably have a good anastomosis to use during the procedure. So we didn't use it for it.
No, and in these cases, you had to use two approach, and you have to puncture the both femoral arteries, and I think it's not advisable, and I think it's not a good option.
Okay, I think we have a question from Dr. Lingham, who is asking what is your first go-to microcatheter, but I believe that each of you have covered it.
In Poland, it's Magic 1.5.
Okay. Then last question from Dr. Farouk Hassan. Do you inject calcium channel blocker for the ostium of the ophthalmic artery before injecting the melphalan?
No, in Poland, no.
No.
Dr. Jabour?
No.
No.
No. Dr. Bartolini, Professor Sayou? No. Okay, I think we covered. No, we have a last question. What alternate will you suggest when the 3 French long sheath is not available?
We use Vasco 35D as the guiding catheter, and it was our standard, and generally still is our standard for most of the procedures.
When it's not available, I prefer to use a Fargo Mini, 4 French Fargo Mini.
Okay. Thank you. I think we covered all the questions. Thank you for this great talk. Thank you for your time. I don't know if each of you have wants to say some few words to. We still have 230 people online. Okay.
Just one word, maybe we didn't talk about. We didn't shape most of them very well. We shape the tip of the microcatheter. We let it straight, and it falls down to the origin of the ophthalmic artery because it's straight. If you shape it, it would be, in our experience, it's much more difficult to push it in the right place and to have a stable microcatheter.
I just want to say something like, I hate to see the debate become like open surgery for aneurysms or endovascular. There are a lot of conflict of interest here, and I hate to see this debate turning into a debate between the neurointerventionalist, us, and the oncologist, the pediatric oncologist, about which way we need to go. This needs to have IV chemo, systemic chemo is better, or IAC is better. All I can tell you is we've showed new data. IAC saves eyes. IAC should be, in indicated cases, primary treatment. So it's not a competition. It's just both old technique against the disease.
I don't know if you will agree, but sometimes the results are better than expected, because we had some patients that had bleeding, edema, supraretinal edema. We thought that there will be no sites, and the children came out from the treatment with sight, and really decent ones. So our oncologists have great belief in what we are
Yes.
doing, so we are very happy.
Yes, it's good. It's true.
Okay. I think it's time to close this webinar. But before, once again, I would like to, on behalf of BALT, to thanks all the speakers, Dr. Bartolini, Professor Saliou, Professor Jabour, Dr. Requejo, and Dr. Rago. Thank you for the great job you did. I can tell you that I didn't read the comment, but we have a lot of positive comment. People are really appreciate your talks and the information that you shared with them. I would like to also invite the participants to our next webinar, which will take place tomorrow with Professor Chapeau on dural fistula complication, and Thursday on the usage of glue with Professor Rodage. Once again, thank you. And I think we can close the webinar here.
Thank you.
Thank you. Bye.
Thank you. Thank you. Bye.
Bye-bye.
ophthalmic artery got at least a little bit of spasm. I skipped something. And this is the patient with the direct ophthalmic artery. And we have a coronal blush, so it's okay if we deliver drugs. And of course, we have to have in mind that there are other ways of achieving it through the posterior circulations. We don't do it. We are a little bit afraid of going through the vertebral artery. And of course, the balloon technique. We haven't done it for less than 2.5 years, but historically we used it. We got better with the manual method, and that's when we stopped using the balloons.